Thank you very much for inviting me. So, as I say, I'm Keith Langmack, Head of Radiotherapy Physics, like my colleague Matt at Nottingham University Hospitals, where we treat around 3,500 cancer patients a year on our 6 linear accelerators. So I've been doing this for over 30 years. But what I'm going to do today is to try and give you a brief overview of what radiotherapy physics is. It's going to be a bit of a whistle-stop tour and is necessarily just going to be very brief. But there are links in the presentation to allow you to go and research more if you're interested. Okay, so an overview is, first of all, how important is radiotherapy in treating cancer? I saw there was a question earlier about how successful is it. A little bit of radiobiology so that you would understand why it works. Some of the science behind it, a little bit about safety, and a tiny glimpse into the future. So, the role of radiotherapy in cancer treatment is basically about 50% of all cancer patients. There is some indication somewhere through their cancer journey that radiotherapy would help. About 2/3 of these are done with curative intent, either alone or with other treatments. And there's lots of estimates out there of exactly how many patients would benefit from radiotherapy, and that's a paper there that was published in Radiotherapy and Oncology now a few years back, looking at evidence-based cancer treatments and where radiotherapy fits in. So this is quite an old slide, but it basically shows how important. So patients who got cured of their cancer, what treatment did they have? So about half of them had surgery, 40% of them had radiotherapy, and 10% had chemotherapy. So it shows that actually of patients who get cured of cancer, surgery and radiotherapy are far more effective than drug therapies alone. So I'm now going to give you a little video of what a radiotherapy treatment looks like, which will basically underpin the rest of the lecture. So this video is from a company called Varian, that is sort of advertising an advanced radiotherapy treatment called Rapidarc. So we've got a patient here laid on the bed. They're head and neck patients, so they're immobilized there. At the moment, we've got a normal X-ray set sending X-rays through the patient to an imaging panel to take a cone beam CT. So it's effectively a CT scan of this patient, which will allow us to deliver precise therapy. So after 30 seconds or so, the CT is being done and then reconstructed, and then that is put on top of process called fusion, on top of the CT scan that the patient has been planned on. And this is the showing the radiographer or technician checking to see what the shifts are like, getting the computer to calculate shifts to put the patient back into the right position, where we're looking at millimeter accuracy here. And then once the computer's calculated the shifts, they're double checked by the radiographer. And once they're happy, you can actually send those shifts automatically through to the table that the patient is lying on. And that will move automatically, putting the patient in the right position for the treatment to be actually delivered. So basically that's done. And this is all in real time. and then we can start the treatment. So this is the treatment head here. Inside there are these thin tungsten leaves making up what's called a multi-leaf collimator, an MLC. And as you can see, as the machine rotates around the patient, there's different shapes of fields going in. The dose rate is changing, and you can see different amounts of radiation being delivered to a particular slice of the patient. So you can just about see the outline of the patient coming up here. The tumor itself is horseshoe shaped, so we're trying to build up a high dose of radiation here. And you'll start to see there are holes in this. So there's a hole here where the spinal cord is, because you don't want to put too much radiation into the spinal cord, otherwise the patient will become paralyzed. But we're also carving out some low dose area here, which is where the salivary glands are. And if you overtreat those, then the patient will get a permanently dry mouth, which is unpleasant. So they need medication for that for the rest of their lives. So there we are. So basically the treatment is finished, and we've produced this high dose area here while avoiding the rest of the patient. So in under 5 minutes, a radiation treatment can be delivered. So that would be 1 fraction out of possibly 35 in a course of treatment. So how does radiotherapy work? Well, you need to know a little bit about radiobiology to understand that. Now that is basically a whole subject in its own right. You can do a whole master's degree in radiobiology, but basically it describes how living tissue responds to radiation. And what we're going to look at now is some cell survival curves, because that will help us understand why we give radiotherapy in the way that we do. So this is a cell survival curve. So we're showing survival fraction here. It's on a logarithmic scale. So 1, 1,000th, a millionth, a billionth. And as there's about 1 billion cells in a tumor, you want to get down to this level also to cure the patient. So if you give 20 gray in one go, you can get to that sort of level. If you split it up into 8 gray single fractions, you have to give about 30 gray. And if you make the size of the fraction smaller, down to 2 gray, you then have to give about 70 gray. And if it goes as low as half a gray, then you're giving, you need to give 100 gray. So you would think the most efficient way to treat everybody was to give them 20 gray single fraction, and that would be everything dealt with. Unfortunately, people don't just consist of tumor, they consist of normal cells as well. And what you don't want to do is cause too many side effects to the normal cells. Now, normal cells and tumor cells respond differently to fractionation. So what we need to do is limit the side effects while delivering an effective treatment. So if we give 8 gray, then this is side effects on normal cells. So actually the normal cells are being killed more efficiently than the tumor cells. And that's obviously a bad idea. You want to kill the tumor cells more rapidly than the normal cells. And this is what you can do with half a gray. But that will take a very long time to deliver. So actually, the traditional approach is to give a 2 gray fraction and give that 30, 35 times or so. So that does the radiobiology. So now on to the physics. So in some respects, if somebody asks me what is my job, and I say I'm a radiotherapy physicist, and they look confused. So basically it's about getting the right amount of radiation into the right place. And there are lots of ways lots of things we need to do that. We need to make sure the dose is accurate, so there's a lot of measurement of doses. But as we've just seen with the treatment, we have to predict the dose in the patient. So that's the process called treatment planning, which consists of both imaging for planning it and imaging for delivering it. And quite a lot of this is joined together when you commission the machines. And it's also very important to continuously do quality assurance on the equipment to make sure it's working properly. Now, if you're interested in how a LINAC works, there's a link here to a YouTube video from Elekta on how their LINACs work. So, measuring dose. So physical dose is measured in energy absorbed per unit mass, so joules per kilogram, but is given in a special unit, the Gray. And that's related to the biological effects. The more dose you give, the more biological effect you get. Now, in terms of measuring it, there are national standard laboratories. So we have the National Physical Laboratory based in London, and that has a basically a graphite calorimeter, which is a block of graphite that is thermally insulated from the rest of the world. They give some radiation to it and measure the temperature rise. And the temperature rise is of the order of millikelvin, so really small rises in temperature, so they have to be really precise. That's not practical in a hospital setting. So often we use a ionization chamber, which is basically a central electrode surrounded by another electrode, and filled with air, and you ionize the air and measure the charge so released. And to relate that charge measurement back to the Gray, there's what's known as a code of practice that allows you to convert the reading that you have to a national standard reading. And the IEA has lots of good descriptions of how that is, and that's an international protocol, and lots of countries will follow the IEA protocol for radiation dosimetry. But that guarantees the Gray given in Nottingham would be the same as the Gray given anywhere else in the world. So that's one thing physicists get up to, and this is a range of ionization chambers. These ones are from PTW because they have some nice pictures on their website. So this is a standard pharma chamber which is used for reference dosimetry. So you collect the charge in here, there's a little bit of air in there, there's about 300 volts across it, and you put it in an appropriate phantom block to be able to measure the dose accurately. Moving on to LINAC commissioning and quality assurance. So whenever we get a new LINAC, we spend quite a while both making sure that it's working properly and collecting baseline performance data. So it's calibrated and a variety of performance parameters are measured and documented. One of the most important things is beam data for treatment planning, and we'll go into that in a minute. Again, the IEA has a number of recommendations, but there are lots of national bodies that do. IPEM have a link to their report there, and IPEM, Institute of Physics and Engineering in Medicine, which is a UK body, has its report 81, which is a massive, thick document that documents what quality assurance needs doing on LINACs. And there are different frequencies of these checks. So daily, we need to just make sure that the calibration is correct, and we use a quick check device for that and check that the safety interlock systems are working. And there are some things that are done less frequently, weekly and monthly, and sometimes annually. And quite a lot of those are also performed after any repairs or maintenance is done, or servicing. Treatment planning, in some respects, is also at the heart of radiotherapy. So beam modeling is, so this is one really important part. So this is some of those beam data that I mentioned earlier when you're commissioning the LINAC. So this is what's called a depth dose curve. So it's relative dose against depth in centimeters. And you'll see the dose for megavoltage photons is actually not at the surface, but a few centimeters underneath it, depends on the energy. So typically for a 6 MV beam, you'll be 1.5 centimeters. That's because the electrons released at the surface go forward into the patient before they deposit their dose. So you get this as a typical megavoltage photon curve. And this is a profile, so this is across the beam. So you can see it's basically flat and then cuts off quite rapidly at the edges. So you take lots of data, this in a plotting tank, which is basically a large tank of water with a mechanism for precisely putting a chamber in a variety of places. And that data is fed into the treatment planning system. And it depends on each treatment planning system exactly how you do that. But in the end, you produce a model which you then test and validate, which will then be used to predict the doses on every patient. So the beam parameters that you sort of saw during the delivery, where all those shapes were done, this system will produce those. So in terms of a clinical process, there are many people involved. So the oncologists are the doctors. And we have therapy radiographers who are radiographers trained in delivering radiotherapy. And then on the physics side, we have the clinical scientists and the practitioners or technicians. So a patient will be referred for radiotherapy. We might produce some immobilization to keep them in the right place. We saw some with the head and neck patient. They go on, have a CT scan, which is done by a radiographer. Then the bits we don't want to treat are outlined by people who have been trained to do that, and that can be any of these people. Usually the tumor is outlined by the doctor because they have all the knowledge of the individual patient. It goes through to treatment planning, where basically the CT scan is used to calculate the dose, and various parameters are changed to give it the required plan. So you're giving a uniform high dose to the target while avoiding the organs at risk. The plan's checked, the doctor approves it, and then comes out of the treatment planning system and into the treatment delivery unit, and treatment's given. And this is a standard prostate treatment plan. So this is a sort of cross-section through the pelvis. Prostate is sitting in here, and these are indicating various little doses coming in from all these different directions. So you wrap the dose into the prostate while avoiding, this is the rectum here, because if you over-irradiate that, you could cause diarrhea to the patient. So we're avoiding the rectum and we're avoiding the hips. So imaging. Basically, there are two areas for imaging in radiotherapy. There's treatment planning, and then there's verification. So treatment planning, we will take CTs, draw outlines of the various organs on that, and use that to calculate the dose. Magnetic resonance imaging is very good at defining soft tissue, so that can be used to improve the outlining. And then there is PET-CT, positron emission tomography, combined with CT, which you can introduce radioactive traces to see the metabolically active tumor, but it's a bit blurry, so you do have to be a little careful at interpreting how we use that. And then for verification, so we've seen earlier the cone beam CD, so that 3D image can be fused with a planning CT to make sure the patient's in the right position. Although you can use the beam itself and something called portal imaging to give a 2D image, the equivalent of an X-ray really in diagnostics, but that is much lower contrast because of the high energy. The bones don't show up particularly well. So that's a whistle-stop tour of treatments. However, radiation is dangerous, so there are some safety requirements, and that's for both staff and patients. So ionizing radiation needs controlling because it can cause cancer and can cause other injuries if not used correctly. You know, if you give enough dose, you will kill somebody. So the ICRP has some information on what are safe doses. The dose rate inside of a bunker can be as high as 15 gray per minute. As the lethal dose is 5 gray, then obviously you can understand that you need to have lots of safety precautions into getting into where a treatment is being delivered. And in the UK, we have some annual dose limits. So for radiation workers, it's 20 millisieverts. And for X-rays, the sievert is basically the same as a gray. For normal workers, it's 6 millisieverts, and for members of the public, it's 1. So actually, you need to get the doses reduced outside the treatment room by factors of 1 million or so. So you need specially designed rooms to do that, and part of the work of physics is to help design those bunkers. But also one way of keeping patients safe is training requirements. So there are, in Europe, there's some basic safety standards which describe who can request, authorize, and deliver radiation in a medical context. And that lays down both the underlying education and training for the staff and processes by which they're authorized to undertake the roles. And in the UK, we have an accident reporting system so that if we treat the wrong patient or the wrong site or give the wrong dose, then that is investigated, learned from, and it's reported to a central authority. That way we learn from accidents. Last but by no means least, there are ongoing developments in dose and fractionation all the time. There have been a number of trials. So when I started, for example, breast cancer was treated in 50 gray in 25 fractions, 2 gray per fraction. Then there was a trial called START, which decreased the dose to about 42 gray, but decreased the fractionation to 15 fractions, so increasing the dose per fraction, and that proved to be equally as effective. And then recently we've had another trial that shows that actually if you, again, decrease the dose to 26 gray, but give that in 5 fractions, then again, that is equally effective. So for breast cancer in the UK over the last few years, the number of treatments has decreased from 5 weeks of treatment down to 1 week of treatment, so making it much more accessible for patients. You can't avoid the use of artificial intelligence. There are now a number of commercial programs that can help you do outlining for at least organs at risk. And there are various approaches to automate planning using AI as well. So there are a number of AI projects that are possible. There's also a number of new delivery techniques. There are two Linacs that don't have cone beam CT, but they do have an MR scanner built in. So there are links there to the website of the two companies that produce those. There are some advantages of using protons and heavy ions for radiotherapy. They have a much more precise depth dose curve, so you can target the radiation more precisely. However, they're incredibly expensive to build. So the UK has only 2 proton centres in the NHS, and that came in at about £250 million for treating around 1,500 patients a year. So protons are very expensive. Something slightly strange that has recently been discovered is something called flash, where if you give really, really high dose rates, the normal tissue doesn't get as damaged, much less than the normal tissue. So there are a number of experiments going on with that, and again there is a link there. And then there are a number of combinations with drugs, so radiation enhancers and protectors. And the latest exciting thing is immunotherapy. So the radiation causes the cells to be disrupted, releasing molecules into the blood, which can trigger the immune system, and modulating the immune system with some drugs can perhaps enhance that, so improve the outcomes there. Been particularly effective in treating melanoma. So in summary, basically radiotherapy is an effective cancer treatment. It uses high technology radiation delivery systems, Linacs, plus imaging techniques to deliver highly accurate and precise radiation doses. There are lots of opportunities to use physics in doing that, from straightforward measuring of radiation doses and calibrating Linacs to developing treatment plans. And all the time there are various things increasing, technologies coming in to be constantly keeping us amused. So I shall stop there so you can ask questions.